Okay. Good morning, everyone. Welcome to the FPMRS Fellows webinar series. This is a joint effort between AUGS, SUFU, and SGS, and we are grateful for their support of this endeavor. I'm Aparna Ramaseshan, the third-year fellow at Hartford Hospital, and I will be moderating today's webinar. Today's webinar is Pelvic Floor Imaging, presented by Dr. Abbas Shobeiri, Vice Chair of Gynecology at Innova Women's Health and Professor of Obstetrics and Gynecology at Virginia Commonwealth University. He will be joined by Dr. Jonia Alshiek from Technion Medical School and Dr. Milena Weinstein from Massachusetts General Harvard Medical School. Our panelists today include Dr. Lieschen Quiroz from Oklahoma Health Sciences and Dr. Ghazaleh Rostaminia from North Shore Hospital. Next slide. In case anyone watching is here for the first time, I'd like to briefly review some housekeeping items. The webinar is being recorded and live streamed. All participants will be on mute, but please use the Q&A feature of the Zoom webinar to ask any of the speakers questions. We will try to address as many as we can within the hour. Use the chat feature if you have any tech issues. AUGS staff will be monitoring the chat and can assist. Next slide. At the end of the webinar, you will be prompted to complete a brief survey and provide feedback about the session. I also wanted to let everyone know that our next webinar is scheduled for Tuesday, May 5th at 5 p.m. Eastern on bladder and urethral injuries by Dr. Elizabeth Mueller. Please visit the AUGS website to sign up. Next slide. Today's webinar will feature brief 10-minute presentations from our three speakers, followed by the presentation of some clinical cases from our panelists. We will open the webinar to questions from the audience for the final 15 minutes. I will now turn it over to Dr. Shobeiri.
Sorry. Thank you. So basically what we'll be presenting is what has been presented within this document from the AIUM that was published about a year ago. And for those of you who are interested in pelvic floor ultrasound and imaging and certification in this, whether you are a fellow or you are an attending physician, the AIUM has set practice parameters to obtain these certifications, realizing that not all the fellows have access to either mentors or the equipment to obtain this certification. The question that is frequently asked is, what is ultrasound good for? And what I can say is that the ultrasound is basically as good as you make it to be. And in this graph, what I have tried to illustrate is that on the left side, you have various urogyne problems that you can encounter. And it's the majority of problems that you would see in your practice. And on the x-axis are the various ultrasound modalities available to you. So the numbers below the technical confidence shows the numbers that you should perform just to be able to use the ultrasound machine. And the one on the y-axis shows the numbers that you need to do to just be good at seeing those different conditions. So you can see that if you correlate the x and y-axis, For you to see pelvic organ prolapse, you just need a 2D perineal probe, and you would be able to see it after probably doing 10 of these, versus if you graduate to doing 3D pelvic floor ultrasounds, you would need to have done more of them, and you would need more expertise, but you would be able to see things like avulsion and vaginal cysts easily. And when you have done a lot of these up to 60 to 70, and you can do 3D anal echodiphagography, then you can see things such as intussusception and perineal fistulas. So that's the answer to the question people ask most frequently. There are really no contraindications to doing ultrasound unless the patient has pain, unwilling to consent, or they have an open wound in the vaginal area. And we do these either in the left side or the lithotomy position, depending on the cultural preferences. Mainly, there are two types of ultrasound. There's introidal and the perineal ultrasound that Milena is going to present on. And there's endovaginal and the anal ultrasound that I will be presenting later. You need to obtain a permanent record of ultrasound examination in your medical records in order to be reimbursed for your effort. And these are the codes that we generally use for vaginal and rectal ultrasound. You can see that there are codes for imaging, and there's also code for 3D reconstruction. At this point, I'm going to turn the podium over to Dr. Alshiek to present on pelvic floor anatomy.
Good morning, everyone. So I will be presenting about pelvic floor anatomy, the normal and abnormal. So let's start from the normal pelvic floor anatomy. And in order to talk about normal pelvic floor anatomy, I would like to point out 4 different components: the urogenital hiatus, the supportive structures of the pelvic floor, the levator ani muscles, and the anal sphincter. So if we sit here on the top of the sacrum and look into the pelvic floor, superiorly, we will have the pelvic floor diaphragm that is composed of the levator ani and the coccygeus that I will be talking about them later. And this hole that is physiological and normal hole in the pelvic diaphragm is called the urogenital hiatus. So let's go inside this urogenital hiatus and use the room analogy. So if we use this room analogy and look at the door of the room, it will be the pelvic floor hiatus. Let's divide this room into anterior, middle, and posterior. So the anterior compartment will be the home for the bladder. The middle compartment will be the home for the vagina, and the posterior will be the home for the anus. The pubocervical fascia will separate the anterior and the middle compartments, and the rectovaginal fascia will separate between the vaginal and the anal canal. The floor will be the levator ani muscle and the walls too, and the roof, the ceiling will be the pubic bone. The attachments between the pubocervical fascia and the lateral walls will be the arcus tendineus, the anterior, and between the rectovaginal fascia and the lateral walls will be the posterior arcus. This frame is the perineal membrane. And now if we go to the supportive structures of the pelvic floor that keep this room upright, I'm going to use the bridge analogy that is very famous and we all know. So look at those two masts, the red ones. This is the ischial spine and this is the pubic bone. And here the yellow structure is the perineal body and this is the sacrum. We see that from the pubic bone to the ischial spine, we can see the arcus tendineus, the anterior one, which called the arcus tendineus levator ani. And from the perineal body in the posterior compartment, we will see the posterior arcus that will be continued by the uterosacral ligament. And this is the anococcygeal ligament. Those fibers that are marked in blue, those are the fibers of the levator ani. So let's look at the organs on this bridge. We have the bladder, the vagina, and the rectum. And if we go to the room analogy again and use the Delancey's levels of support, we will have the level 1 that is composed of the uterosacral and the cardinal ligament, and it keeps the room upright. In the lateral attachments that attaches the walls of the room to the pelvic floor, this is the level 2 support, and the level 3 is the perineal membrane. And we all know this famous picture of the Delancey, the level 1, level 2, and level 3. Now let's talk about the levator ani muscle and its subdivisions. This is one of the most important things that we can perform ultrasound and have all the subdivisions. So as I mentioned before, the levator ani is the floor and the lateral walls. And if we look into the pelvic floor, we will have the pelvic diaphragm that we saw at the beginning. And if we separate this pelvic diaphragm, it's like a half ball, and it keeps the room upright and supported. And if we look into the subdivisions, so the first one is the pubococcygeus muscle that goes from the pubic bone to the coccygeus, to the coccyx, and then we will have the puborectalis muscle that goes from the pubic bone around the rectum and forms a sling behind the rectum and has a very important role. This is the pubovaginalis muscle, and this pink marked muscle is the is the iliococcygeus muscle, the left and the right, and this is the coccygeus muscle. If we go to the bridge analogy again, those fibers crisscross, and it's highly important to understand that they cross each other, because when a woman has obstetric injury, in some of the fibers, the other fibers will compensate and she will still have a good function. And looking at this scheme that is very clear, here is the urethra, this is the vagina, and this is the anus. If we look at the muscles, this is the external anal sphincter. This red sling is the puborectalis. The pink muscle is the puboanalis muscle. And this is the perinealis muscle that goes from the pubic bone to the perineum. And the pubovaginalis is very small subdivision of the levator ani. And this is the iliococcygeus subdivision. And now I would like to mention the anal sphincter, because this is also one of the things that we would like to demonstrate or illustrate when we do ultrasound. So we have the external anal sphincter and the internal anal sphincter that we see in this scheme. And if we look at the ultrasound, the external anal sphincter, which is intact in this patient, it will be a hyperechoic in the ultrasound, and the hypoechoic ring will be the internal anal sphincter. And I won't show you more ultrasound images. Dr. Shobeiri and the other speakers will talk about ultrasound. This is how we see it in cadaveric dissection. External anal sphincter that is more caudate, and this is the internal anal sphincter that is more cephalad and also medial. And now I would like to go over some of the very beautiful dissections that we have done in the past. So just taking right hemipelvis and looking here on the posterior aspect, this is the coccyx and this is the pubic bone here. Here we don't see it very well, but it's here. And I will start from the organs. So the bladder is here open. This is the vagina and this is the anus. And here is the rectum. If we go over the muscles, so here we can see the pubococcygeus muscle very beautifully that goes from the pubic bone to the coccyx. This is the puborectalis muscle that is deviated, and it goes from the pubic bone around the rectum, and then as I showed you before, it forms a sling. and this is the iliococcygeus muscle. And just to make it easier, we colored the muscles, and this is the iliococcygeus muscle. This muscle that goes from the pubic bone to the coccyx is the iliococcygeus muscle, and this is the pubococcygeus muscle, and this is the pubocriptalis muscle that forms the sling. Going more caudally, this is the puboperinealis in yellow, and this is the puboinalis in red. And again, it's very important to try to understand what are the different subdivisions, because when we perform ultrasound, we really can see and can illustrate all the different subdivisions. This is the anal area. So the anus is here, and the vagina is here, and this is the external anal sphincter, and more laterally and superficially is the superficial transverse perineal muscle. This is the perineal body, and this is the puboinalis muscle that we can see the right one and the left one. Again, if we understand the different subdivisions and we can recognize them, we know the anatomy, we can, when we perform an ultrasound, so we can go over one subdivision and understand what is the exact one. And now, just after we just presented the normal anatomy, I would like to go over some of the abnormal anatomy, and starting from the anterior defects. So when we say anterior defect, the result is cystocele that we all know, but it's highly important to know what is the exact pathology. So for example, we could have cystocele when we have partial or complete midline defect in the pubocervical fascia. We could have cystocele also if there is absence of the pubocervical fascia. And we can have cystocele if we have unilateral or bilateral defect in between the attachments of the arcus tendineae and the anterior fascia, which is the pubocervical, or we can have cystocele if we have sagging of the pubocervical fascia due to defect in the levator ani muscle after delivery or after pelvic trauma. When we talk about the posterior defects, again, we can have rectocele due to midline defects, partial or complete. We could have rectocele due to absence of the rectovaginal fascia, or because of lateral defect in the posterior wall, as we can see here, unilateral or bilateral. And again, also obstetric trauma, we all know it's very important to understand all the etiologies, the 3rd and 4th degree, and the anal sphincter injury that the other speakers will be showing us the different injuries in the anal sphincter. And I would like to summarize my presentation by saying that knowing the anatomy is highly important for us to be able to perform ultrasound, because when you know the anatomy, you know what you are seeing in ultrasound. And today we have different advanced ultrasound technologies, and the ultrasound can increase our ability to detect pelvic floor defects and give a better repair and better solution for the women that have different defects in the pelvic floor. Thank you for Dr. Shobeiri for his book that I used for some of my images. And thank you for listening. I will stop sharing and go to the next speaker, Dr. Milena.
Better unmute myself. Good morning, everybody, and thank you for this wonderful opportunity to present to everybody on the ultrasound. So here are my disclosures. I know by now everybody probably feels that we want to, reinstall this year, but the silver lining is we can be doing this, which is, I think, fantastic. As Dr. Shobeiri mentioned, we were part of putting together these parameters, and some of the things that I'm going to discuss today, mainly about introital and perineal ultrasound, are part of the parameters. So my objectives today is very briefly go through the perineal, introital, pelvic ultrasound to assess the anorectum, the pelvic floor hiatus. I will very briefly talk about the slings and very briefly discuss a case. So as we just saw, obstetric sphincter injury is certainly one of the conditions that we assess, and it's absolutely renders itself very nicely to ultrasound. And the reason for this, and by the way, this is an image of a patient that saw me after she went to her midwife for a 6-week check, and midwife said everything is normal. And then you do an exam and you say, there's something wrong, right? There's sounds like a sphincter injury, and she actually could feel something different. So the truth is we're really not that good at detecting the anal sphincter injuries by exam. This is a nice study done in England that looked at assessing appearance of the sphincter, so looking at the dovetail sign as well as the digital exam. And there's some variation on this sensitivity specificity, but it's certainly not perfect. And you would wonder is what did they actually use as a gold standard? Well, the gold standard as it exists now is the endoanal ultrasound, which has been studied very well and popularized by Dr. Sultan. And there's a seminal paper, which for the fellows in the audience, they should probably look at that, where they looked at the endoanal ultrasound and looked at his correlating histology. And it still is a gold standard, but the truth is not all of us have this imaging available. Not all of us have these pretty expensive equipment. And so a lot of times what we're left with is what many of us who work in a framework of OBGYN departments, this is much more accessible equipment. So these are equipment that I will be talking about. So the transducers that are endovaginal transducers, which we use for introital imaging, and the abdominal transducers that are, both of them are not a circular array transducers, but rather the way we assess the anal sphincter is shown here. So for the pelvic floor ultrasound using the abdominal as well as introital, the orientation is on the perineum or introitus, and we should be pointing that transducer towards the anal sphincter. And the resulting imaging, which we'll look at in a second in detail, is looking at initially, especially if we just want to sort of go on that along that trajectory that Dr. Shobeiri nicely showed. If we would just want to look at 2D, this is what we find. So we say, okay, here is a transverse image of the anal canal, and this is I happen to show an example of a endovaginal transducer, but this is very similar with using an abdominal transducer. So to look at the details, because the imaging that we're looking at is different than the endoanal imaging, very much so, because the transducer is not introduced through the anus, obviously. So the first thing that we see that's a little different is that there's actual definition of a normal folded anal mucosa. So this is what people describe as a mucosal star. And this is an example of very normal appearing mucosal star somewhere in the middle of the anal canal. The next layer, which is the hypoechoic, so it's dark, is the internal anal sphincter. And this is kind of a very classic appearance, again, of the mid-anal canal, where internal anal sphincter encircles the entire canal. As we go more distal, which I'll show you in a second, this actually can disappear. And again, that is normal. And the next layer, which is sort of much more hyperechoic, so brighter, some people call it a mixed heterogeneity layer, is the external anal sphincter. And again, this is the appearance of normal, and this is 2D. So how do we then look at this in 3-dimensional imaging, which is what's going to be our next step. So here is a 3-dimensional imaging of the anal canal. So we have, again, the probe, which I actually didn't show here, is the transducer is placed here. So we can see the sagittal section, the transverse section, and a coronal section. So the classic appearance of the anal canal that we're all used to looking is at that transverse section, but here we actually see all the different planes. And as we go through the orienting us to what we're seeing, so we can see the perineal body, which is right there. We can see the sagittal section of external anal sphincter, more proximal in the anal canal, because this is the entire anal canal. We see the puborectalis muscle. And again, that hypoechoic, the darker internal anal sphincter, and then up higher is the rectum, which is sort of above our view. So if we say, okay, if we take this image and we make a cross section, which is what the 3-dimensional image allows us to do, and this is a cross section of the proximal anal canal, what we see here is the puborectalis muscle that surrounds the anal canal and forms the anorectal angle, and we still see the internal anal sphincter, which is hyperechoic. If we make a cross section in the middle of the anal canal, which is the classic view that I showed earlier, we see this sort of a targeted appearance of the anal sphincter, and again the that normal anatomy that I just described, the external sphincter, the internal sphincter, and we see the mucosa. And also noted here, this actually happens to be an artifact. And that's something that we're always mindful of when we do this imaging, is there can always be introduction of an artifact. So here's an example of yet another presentation of what normal looks like before we go to abnormal. And this is a tomographic imaging. So similar to what I just did, we have a 3-dimensional image. And so tomographic images allows this really fine cross section along the entire length of the anal canal. And at the proximal end, we start seeing that the puborectalis comes into view and there's no more external sphincter anteriorly. And as we go more distally, we start losing the definition of the internal sphincter. And again, that is normal part of anatomy because the internal sphincter ends a little bit more proximal as the external, as the superficial layer of the external sphincter is located very distally. So how do we then recognize the pathology using this technique? So this is actually a very nice paper that highlights the different aspects of how we recognize the different parts of sphincter damage. So one of those things is thickening of the external anal sphincter where the scar is probably located. And one of the other signs, which is actually a very classic sign, is this thinning of the internal anal sphincter, especially if it's part of the sphincter, of the sphincter rupture. What we also see is the thickening of the opposite side of internal sphincter, and this very classic appearance, what's called the half moon sign, as shown and highlighted in orange. And the next thing we see, and actually it's also seen in these other panels, is the mucosal folds that had this really nice kind of appearance of the star start being pushed towards the area of defect. So they're kind of almost like, look, they're being sucked into where the defect is. And here's an example of one of my patients. And again, there's a similar distortion in the half moon sign in those cross-sectional imaging. Before we switch gears and talk about other modalities, I just wanted to bring up, there's only one trial that actually compares this imaging to anal imaging. And I would say that even though this is absolutely an acceptable modality, and I think if we don't have access to endoanal imaging, we should absolutely be using this. At least for now, the sensitivity and specificity is not quite as good as the endoanal imaging to detect the sphincter injury. So hopefully more to come and more studies to be done. And you know, as we get better at recognizing this, we may actually improve some of this too. So switching gears, what I wanted to talk to you about, looking at the pelvic floor anatomy in 2D and then in 3D. So we first will start with 2D. And we just had a very nice review of the anatomy, but now we're going to look at that anatomy and correlate it with what we see as we place the ultrasound transducer and look at the sagittal view. Again, this is two-dimensional. Before we get three-dimensional. So here we have the pubic symphysis, which is the bright structure anteriorly. Again, I flipped this anatomic cartoon upside down just because that's how we see it on ultrasound. The next structure we see is the urethra. And in this particular patient, the bladder is rather collapsed. So it's not, doesn't have quite as full bladder as we'd like. Here is the outline of the vagina. Here's the cervix. We see the anal canal and then the rectum. And then we can actually very nicely see the anorectal angle, which is again formed by the puborectalis. So if we take this and say, okay, well, how do we then take a three-dimensional image out of it? So I have something similar that I actually did way back at UCSD. The same sagittal image, which we just went through. So again, urethra, bladder, vagina, and then anal rectum. And then what 3D imaging allows us to do is then we can connect inside the three-dimensional volume, the pubic symphysis and the anorectal angle, and then see this classic appearance is starting to look like those nice anatomy images, right, of the hiatus. And the structures that are highlighted here is this axial or transverse image of the pelvic floor hiatus. So looking anteriorly is the pubic symphysis, the urethra, this very classic highlighted butterfly shape vagina. Again, this is normal, and then cross-section of the anal canal, and then of course the levator ani, which is most likely the puborectalis that surrounds the hiatus. So when we do the pelvic floor ultrasound, this is actually what we look at. So here is this is kind of the classic representation of the orthogonal planes. And again, this is looking at just at normal anatomy. We see the sagittal, we see the coronal view. The sagittal view we just saw, which is what we call an acquisition plane, and then the axial view. And all these are at 90 degrees to each other. And the same, this marks the same spot in all those images, which is called a dot marker. And again, we'll go through this anatomy kind of quickly. Pubic symphysis, the urethra. Of course, we can only see bladder sagittally, the vagina, the anus, and then as we take take the cross section that I just highlighted, so this is what's called a rendered image. So what we did is we actually took an integrated image, and some people call it a thick slice image across the section, and now we can actually see the definition of the muscles surrounding it and the respective anatomy and the levator ani muscles that surround the introitus, but this is more an integrated image, so we can actually see the multiple muscles here. The reason why we want to see this, and again, we already alluded to this, is that we do know that vaginal delivery is a huge risk factor, and then these muscles that we just looked at are can be incredibly compromised and probably go through like a 300-degree stretch as the head comes through the pelvis. And there is at least one theory that what happens is that the levator anis get avulsed off their origin. And what we can see is we can actually see this trauma on the ultrasound. So here's an example of what, again, normal looks like, looking at that thick slice or rendered image. And here are examples of some abnormal. So again, we see the distortion of the anatomy here, distortion of the outline of the vagina, and here practically absence of the muscles, and a lot of asymmetry compared to what normal looks like. Here's an example of what dynamic image would look like, and I'll show you a couple more dynamic ones. Here's somebody who has a resting image, and I'm sorry it's a little fuzzy, and then as she strains, where the defect happens, there's almost like more distortion that happens towards that side as things get pushed out. in a brief video that shows what live 4D looks like. And on this image, we'll see as this woman performs a Valsalva maneuver, she strains, and we actually see this completely distorted hiatus. What we can do with this, we can do measurements, which is kind of highlights some of that asymmetry, which is called levator urethral gap. And I'm actually going to skip some of this just because probably going to run out of time. But we also know that levator NI defects are one of the major risk factors for prolapse. And there's a really great paper by Delancey that using MRI technology showed that the prevalence of major defects in the levator NI muscles, which much higher in women with prolapse. But what I wanted to bring up, and by the way, another sort of thing that doesn't surprise us, that levator NI avulsions were much more prevalent in women who had forceps versus vacuum. But one other thing that I wanted to bring up is that there's also a really interesting anatomic study that actually questions whether or not these injuries were truly avulsions. And in this study, they did ultrasounds on 30 cadavers and looked at the avulsions, and they found some what they called avulsions, but when they did what they called avulsions on ultrasound, but when they did dissections, they didn't see avulsions at all. They did see some thinning, but they did not see the muscle injury that represented an avulsion. So, you know, for those of us who are sort of still thinking about what exactly is happening to these muscles, this is certainly a good area to still study. So what else can we see with an ultrasound? This is actually something that probably clinically I do more commonly than some of the other technologies, looking at the slings. And I know Lieschen is going to cover the slings, but we can see the slings using this technology. Here's a very nice highlight of what the sling looks like, and then a sagittal view of the sling somewhere around the mid-urethra. I will show you a very quick video of what the sling looks like as somebody Valsalvas. Here's a sling, and it moves along the urethra. And these are some of the assessments that we can do to understand how the sling works. There's maybe somebody who has a little bit of a twisted sling, and she also happened to have some pain. And whether or not that correlates with the sling, whether the twisting of a sling correlates with the pain, that's obviously still a question. Here's a representation of what a bulking material would look like on ultrasound imaging. That actually is a very bright structure. A lot of these hyperechoic bright structures, this is bulking material almost entirely surrounding the urethra, and actually she'll also happen to have a sling as well. And a quick case. So this is a patient of mine who had urethral diverticulum. And this is actually a very nice representation of urethral diverticulum. So here's a mid-sagittal view, a coronal view, and an axial view. So in a mid-sagittal view, the urethra is in here. We can see the bladder, and actually very nicely, we can see the neck of the diverticulum. And here's a pretty sizable diverticulum. But what's also really cool about this diverticulum is you can start seeing this here, but you can definitely see it on the axial view. This diverticulum also happens to have stones. So in the axial view, we see the urethra, which is pushed off to the side. This is some urine inside the diverticulum and these really nice stones. And if we look back at the mid-sagittal view, there's also very nice echoes come from the stones, which is very normal findings confirming the stones. So thank you very much. And I will turn it over to the next speaker, Dr. Shobeiri.
Very good. We are going to talk about integrated pelvic floor ultrasound. And just to go back to this graph that I showed you, an integrated ultrasound would be 2D ultrasound married with 2D anal and 2D vaginal ultrasound. And this would really enable you to cover a lot of these other conditions that we have talked about. And I'm going to restrict my talk to really none of these things that you see here. it's going to be just about normal. This is very much an introductory lecture, and for you to gain the deep domain expertise that you need to do a lot of reading and do a lot of ultrasounds to enable yourself to do this. So with the endovaginal ultrasound, the reason we advocate it is that you have a high frequency probe placed either inside the vagina or the anus, and you're looking at the tissue head on right there. So you can see the MRI right to the side here of the same patient. The patient has a suburethral mass, and you can see the mass here, and you can see the mass in the MRI. But when you look at the levator ani muscle here in the MRI and you compare it to all these single fibers that you are seeing on the ultrasound, you just go, wow, this is an amazing imaging. We have done studies to show similarity of technologies, but you can see a lot with ultrasound. We start with a 2D transperineal probe placed between the labia. And we want to make sure that we get the pubic bone and the levator plate for the image that we are obtaining. And the distance from the pubic bone to the levator plate is what constitutes your minimal levator hiatus. And what's different probably with the 3D perineal ultrasound and this modality that we put our images right side up means as if the patient is standing up with facing forward pretty much. And so these are what you need to see. The first measurement we are going to obtain is the distance from the pubic bone to the levator plate. That is, in this patient, 51.2 millimeters. And then when we tell the patient to squeeze, you see that she changes the measurement very little. That's because the patient has a muscle spasm of her levator muscles. So her muscles are frozen. She's not moving anything at all. So in this video that I'm going to show you, you can see your probe, your transperineal probe is looking at the vaginal area, and the patient has a resting cystocele. She's not doing anything. You can see the pubocervical fascia coming here. This continues. There's just skin here, and there's pubocervical fascia here. So in terms of your surgical planning, you know that if you went and got this tissue and brought it this tissue with sutures, the cystocele would be resolved. But when you look at the video and tell the patient to Valsalva, look behind here, what she does behind the skin, she literally has this enterocele that sneaks in and it sneaks back up as she squeezes her muscles. So again, another reason to ultrasound people beforehand, because you go and close the cystocele, but the patient will continue having issue or what you would view as a recurrence. This patient has a mesh here. You can see a bunch of stools sitting behind her rectum. And when she Valsalvas, even though the mesh is intact, she's prolapsing into the vagina. This is a sigmoidocele. You can see the content that is a stool. Again, transperineal imaging. And then you can switch off to the endoanal imaging endovaginal and endoanal imaging as we talk about here. With endovaginal imaging, we use a probe, the pelvic floor probe, and we inserted about 6 to 7 centimeters. And as you go in, because the crystals on this probe are lined up here, you would be seeing the bladder as you go in. So you would see the urethra, you would see the bladder, and you could push in further if you want to see something else, but this is where you need to stop for 3D imaging. What you would see, again, in your view is anterior, transducer is inside the vagina, cephalad, caudate orientation, that's your bladder, that's your urethra, that's the pubic bone, smooth muscle, rhabdomyosphincter, and the trigone. Great correlation with histology studies that we have done. In a normal patient, when you tell them to cough, you can see that the bladder neck is not opening. The patient is not having any funneling. When we do this, we press the probe a little posterior, not to obstruct the urethra, but there is good correlation between funneling and fluoroscopy. You turn your probe over such that you can see the perineal body and the levator plate. And what you would do, you would measure from the probe to the levator plate at rest, and you tell the patient to squeeze, and you see the difference goes from 22.6 to 18.4 millimeters. She has good levator lift. And then this will tell you that she's in control of her muscles. And we also can ask the patient to Valsalva, and this has great correlation with digital examination, manometry measurement. Again, great correlation with histology of all the layers that you see on ultrasound. And in this patient, you can see we are asking her to Valsalva. Just keep your eye on this area right here. This is her levator plate. And as the patient bears down, you can see that's the perineum. Levator plate is here. Her levator drops. The rectum is coming down because she's trying to have a bowel movement. And when she's done, look at where the muscle goes back up there again. So this is the levator in action. We ask the patient to squeeze, and you can again look at the levator muscle here. This is the anal canal, the perineal body. And we ask the patient to gently squeeze her muscle, and you can see she just lifts. And you can see different muscles within the levator plate, puborectalis, pubococcygeus are making this happen. So obviously this squeeze function will not happen unless the patient had intact muscles. In this patient, she has a spasm. Look at her levator plate here. We tell her to squeeze. Literally nothing is happening because she just cannot do it. Then you go to the 3D endovaginal imaging. You just push your 3D button, and you would get a 3D volume. And the 3D volume can be analyzed really traditionally the way that you would do on an MRI in an axial, coronal, etc. image. And you can obviously see all those muscles that Dr. Alshiek talked about in axial image, but the beauty of the this technology is that this is your 3D volume. As we go in, you can see the perineal body. You go into where the pubic bone is. You can see the levator muscles here. And just to show you how sensitive this is, you can actually differentiate between the pubococcygeus here inside and the puborectalis here. But this is not the where we want to look at it. You want to draw a line from the pubic bone to the top of the levator plate, and you just twist your plane like this to go find your minimal levator hiatus right there. And then you twist back, and I'm not getting it perfect, but again, you can see that here what you have mostly is the pubococcygeus fibers. A little puborectalis can be seen here, but really to see the puborectalis, you want to go more caudad, and this is puborectalis. This is a very important thing to recognize because when the baby's head is coming through the minimal levator hiatus, it will injure the pubococcygeal fiber first before getting to the puborectalis fibers. And this is consequential because as you go more cephalad and you look at the iliococcygeal fibers, those are really continuation of your pubococcygeal fibers. And when this gets injured, it just opens like a zipper and opens up where you lose the cephalad support of the muscles. Obviously, you look at this axially if you wanted to, but you can turn around and look at the 3D volume in mid-sagittal view, bladder, urethra, pubic bone, etc. Or you can go look at it in the coronal view, and this is very useful for looking at the slings and so on and so forth. And you can see this is a pubic bone. smooth muscle of the urethra. This olive-shaped thing is the, again, the smooth muscle of the urethra. And as we go through the urethra, we get into the vagina, you can see the anal canal, and also that's what we have. So just continuing with our presentation, then you don't have to do endoanal imaging unless the patient has symptoms, or if they are there for anal sphincter injury, or if you saw a defect on your endovaginal imaging. Whether you are using a colorectal probe or whether you are using a pelvic floor probe, you would get exact same images pretty much. We like the pelvic floor probe. It has much better profile and better visualization of the levator ani muscles. So to just show you what an anal ultrasound looks like, I'm going to open up this volume. You see that it's just loading right now. I had the other one ready for you, but here we are. So it's a little dark. I'm going to do this so you can see it. I'm going to enlarge my window. Now on purpose, I have gotten this, a big field of view of this ultrasound. But as we go in, you can see that this is your anal sphincter complex. I'm going to zoom in a little. And you can see, again, the probe is inside the anus. You can see the superficial part of the anal sphincter muscle here. And as you go in, I'm just going to zoom in a bit more. You can see the internal anal sphincter coming to view, the main part of the anal sphincter coming to view. And on top of that, you would see the superficial transverse perineal fibers. And as you go in, again, external anal sphincter, superficial transverse perineal, internal anal sphincter, and then you see the anal sphincter thins out here. And then here we get to the U-shaped sphincter. So if you obtain your image here, you would erroneously basically think that there is a defect where there is not. As you go up further, you can see the puborectalis fibers starts going upward. I'm going to zoom out a little and just show you why this is important. So on endoanal imaging, you can see your levators joining the pubic bone. So you see that. So you have your pubococcygeal fibers here, your puborectalis fibers here, and they're joining the pubic bone. If you are doing an endoanal ultrasound and you do not see these attachments and you're evaluating patient for anal incontinence, you do need to go and do an endovaginal ultrasound to make sure that their levators are intact. Because if their levators are intact, and you go and do anal sphincteroplasty, you would give them obstructed defecation, which is not a good thing to do. Again, you can look at this on the coronal view, and you can see the anal canal, internal anal sphincter, and basically external anal sphincter and the levator fibers. So I went through that a little fast, hopefully not, but as an additional resources, we have the book out there. All the people who are talking on this webinar have great book chapters in there for you. Next, I'm going to turn the podium over to Dr. Quiroz to present the case on vaginal mesh.
Hello, everyone. And I wanted to share a 3D volume. Can you all see me? I wanted to share a 3D volume that's already open for you. So this is a case in which we already have obtained our 3D volume, and we have the transducer in the middle, and we're gonna get we can take a look at this volume, but first starting with our axial view. And that's one of the first things that we need to do in order to make sure that our volume is oriented how it should be. Sometimes you need to go, for example, go to the bony landmarks of this volume. You may need to tilt it. This is the 3D post-processing. You may need to tilt it a little in order for you to make sure that you are optimizing your images. This is one of the key things that you need to make sure that you do. Now that we've tilted it and we make sure that we're doing well, you can actually move in and out of these slices. And in this specific case, we are interested in looking at a sling. And this lady had had a previous history of a sling removal. And so it was unclear from her history if she had had a complete removal or not. And I felt there was a band on the patient's right side that was either more sling or scar tissue. And so in order to verify some of what we're looking at, we can go at this point from the sagittal view, and we rotated our volume. Of course, we go through all the musculature. This is some of the same musculature that Dr. Shobeiri was talking about. You can actually see how these visceral fibers insert posterior to the pubic bone back here. But we're turning our attention instead to this area of sling that we note on here. Now, we can verify that we are indeed looking at a sling, and we can take the time to map out exactly where that is. In this specific case, this patient has had an anterior vaginal mesh as well, and she also had this sling placed. You can actually go in and out and sort of map out where you think this mesh is going. Now, what we can also do is take the coronal view and actually go down onto our images and expand our area of where that sling is. From what you can see over here, we're at the bladder neck, and you can see this with a great level of detail, that you have this entire mesh sling on the patient's right, and you have it where it was amputated on the patient's left. There's nothing left on that side. We can go in and out, and you can clearly see where that sling is located and still going into this obturator space over here. Now, by clicking on this icon, you can go back to your previous one. You can actually make a measurement and note, for example, that the urethral length is, for example, approximately about 3 centimeters. And you can also make another measurement noting that the sling that you're interested in looking at is about the mid-urethra. So even though she does have other areas of scarring, this allows you to minimize your area of dissection so that you're able to, if anything, make sure that you are going straight to where the money is, which is where this mesh is located at the mid-urethra. I hope I'm illustrating this for everyone clearly. I had another quick example that I'll go ahead and point out for you all. And after that, we'll open it for questions. The main other quick example that I had was about a woman who came in with a complaint of gross hematuria. She was going to the operating room for an exam under anesthesia secondary to a possible cervical mass. And can you all see my screen on that? That this was something that was found on cystoscopy at the time of her exam under anesthesia. So she had a mesh arm or a piece of mesh in the bladder that was noted at the time of cystoscopy. Now, on obtaining her operative reports, turns out that she had both an anterior and as well as an anterior mesh as well as a sling. And as you can imagine, it was very important to clarify whether that mesh exposure or mesh erosion is from this anterior vaginal wall mesh kit or from the sling. It was not really some of a question that we needed to clarify before going forward. And so this is our 3D ultrasound. From what we can see on the volume, we can go in and check and see, and this does have the characteristic of a retropubic sling. It's more of a U-shaped sling. You can kind of see it right then and there. Now, sagittally, I'm going to go in and I'm going to show you the area where she had this anterior vaginal wall mesh. And by going in a little further, I can actually clearly see that this area of this mesh that was going into the bladder is clearly continuous with this anterior vaginal wall mesh, completely separate from that sling that is located at the mid-urethra. So this view and this ultrasound does guide your dissection and your operative approach quite a bit. This is another view of that same kind of view. We have that sling completely separate here, and it's located at the mid-urethra. And as we're going in coronally, you then see that this mesh arm on the patient's left is clearly the one that is the culprit in the bladder, completely separate from that sling. It would be wrong to seek out and do a dissection to get the sling out of the way, thinking that you're going to fix this problem. I'm going to, I think I only have time for that. We're 1 minute over. And I'm going to open it up to the rest of the panelists to see if they have any other questions, or I can show you more examples. I'll let Dr. Shobeiri guide that at this point. Do we have any questions to address?
There were a couple questions in the chat, which have been answered, but perhaps we can elaborate a little bit about how you all approach failure of mid-urethral slings. If anybody has a preference on whether you do ultrasound to evaluate the location or type of sling, or do you usually just take a more clinical approach without imaging?
So it all depends. I think that if there is given the fact that I have ultrasound as a tool, it's something that I readily use in cases of when there's a problem with a mesh. As far as why the mesh failed, I think that the dynamic view can actually be useful in evaluating how that mesh sling moves. And we are, I find it quite useful in order to understand if it completely moves out of the way, or whether it was too distal, or the location of it. I think that Dr. Shobeiri had a quick question on here saying that if that's the only question so far, that we have one more presentation to sneak in.
Yes, we will have Dr. Rostaminia do a little case presentation for us now.
Okay, guys. So hello, everyone. I just have a couple of videos for dynamic posterior compartment imaging that I can just show you guys, present that through presenting a case, actually. So we are having so we had actually a patient, 73 years old female, history of pelvic floor surgery, that presented to our clinic with severe obstructive defecation symptoms. She didn't have any urinary or vaginal bulge symptoms at the time. She reported incomplete emptying of a stool or entrapment of a stool in almost 100% of the bowel movement, need to splint, even though she had daily bowel movement and the stool was soft and she was taking Miralax. At the same time, she was able actually to feel the full rectum, meaning that the sensation was sort of intact and she was getting the urgency, but she couldn't completely empty and she had to go inside the rectum and take the stool out. So no significant past medical history. And exam. So in the exam, POCU was relatively normal, no significant vaginal prolapse, a little decrease the squeeze function of the elevators. Anal sphincters looked completely normal, no like rectal prolapse or anything like that, with normal rest tone and actually slightly decreased squeeze tone. So meaning that we have a patient with obstructive defecation, no significant vaginal prolapse, daily normal soft bowel movement, but she can't get it done completely. So what should we do for her for a diagnosis and then treatment? So apparently we should do some sort of testing, anal manometry, MR-difficography or anything like that. But for these patients, actually, we just do dynamic ultrasound easy in the office. So let me show you how the normal looks like for dynamic posterior ultrasound. So you should have, this is a mid-sagittal view. You should have anal sphincter, rectum, posterior cul-de-sac, and levator plate here. So in the normal, patient drops the levator plate. So that's a normal Valsalva and tries to push. And rectum appears sort of stable, you know, there's no folding, falling, or anything like that. This is actually a patient with dyssynergia. When you actually ask to Valsalva, looks like she's squeezing. So these are kind of like, you know, having some idea, and this is actually our patient. So let's look at that. Let me orient you guys. Again, this is vagina here, anal sphincter, rectum, levator plate. She's pushing, and you will see something is coming between rectum and vagina. Ask the patient to push harder. Ooh, you see that. The whole sac of the peritoneum with bunch of the small bowel comes between vagina and rectum, which is a definition of enteroceal. This is the imaging of our patient. And actually, you know, she had MR difficography from like colorectal before coming to us. And so just rectum, vagina, this is the opening. So she tries to empty, and you will see that. So you see that there is no vaginal bulge, so nothing is coming out of the hymen, out from the vagina. Rectum collapses, and that huge peritoneal sac with all the small bowels. And I have that image side by side right now. So you will see that. So sort of actually, you know, by using that modality, I don't remember the last time we did MR difficography for the patients with obstructive defecation. One more patient with enteroceal, and one more patient with actually partial rectal prolapse. Yeah, so that's just a clinical use of that sort of imaging and ultrasound. That's all I have for you guys. Sorry, it's out of time.
Well, it looks like we're just about out of time here. I'd like to thank all the speakers for their participation and for their time today. I'd also like to thank AUGS, SGS, and SUFU for putting together these informative webinars during this difficult time. Just as a reminder, we're putting these webinars every Tuesday and Friday for our FPMRS fellows and others who would like to join. The next webinar will be held on Tuesday, May 5th on bladder and urethral injuries. The speaker will be Dr. Elizabeth Mueller. You can, if you can't watch the live broadcast, you can also watch the archived version on the Society's website or find it on YouTube if you just search AUGS Fellow Lectures. Thanks so much and be well.